Hello, and welcome to the second installment of our How I Practice videos on metastatic urothelial carcinoma. I'm Dr. Tian Zhang, an associate professor and director for clinical research in the Department of Internal Medicine, Division of Hematology and Oncology at UT Southwestern Medical Center in Dallas, Texas. And today I'm really pleased to be joined by my wonderful colleague, Dr. Andrea Apolo, who's a medical oncologist and physician scientist focusing on bladder cancer in Bethesda, Maryland.
Hi, Tian. Thanks for having me.
Over the next few months, we'll be posting a series of these short CME certified videos focused on the management of patients with advanced metastatic urothelial carcinoma. If you haven't already completed your pre-survey, please do so by clicking the link below this video or by scanning the QR code shown here. Let us know who you are in the polling questions below. Also, please be sure to complete your evaluation at the end of the session and claim your CME credits. This activity is jointly provided by PACE and Bonum CE, and this program has been supported by educational grants from Astellas, Gilead, Merck, and SeaGen. Over the next few weeks, be sure also to watch our handles for additional bladder cancer CE programming and follow at Bonum CE for more CME certified programs on Twitter. Turning to our learning objectives for today, we're going to describe efficacy data regarding standard therapies used in treatment of metastatic urothelial carcinoma and think through the selection of appropriate treatments based on the latest guidelines regarding preferred treatment regimens for metastatic urothelial carcinoma. And so today we'll be talking specifically about the role of treatment guidelines in therapy selection and sequencing for metastatic urothelial carcinoma. So Andrea, what guidelines are currently available and can you help us navigate this treatment selection?
Thanks, Tian. Yeah, so there's a lot of guidelines available for the treatment of urothelial carcinoma. Today, we'll focus on three of them, including the NCCN guidelines, or the National Comprehensive Cancer Network guidelines, the European Association of Urology, EAU, and the ESMO, which is the European Society for Medical Oncology guidelines. And the nice thing is that these were just updated to include a lot of the data that have been presented in recent meetings that have really changed the practice and the care of our patients with metastatic urothelial carcinoma. So we'll start off with what are the FDA drugs that are approved in metastatic urothelial carcinoma. So there's been a lot of activity recently with a lot of new agents approved in the metastatic setting and now being tested in muscle invasive and non-muscle invasive disease. So we'll start off with the oldest. So sacituzumab govitecan received accelerated approval by the FDA. That was in April 2021. And it is something that we can use as second, third line, fourth line, so basically second line and beyond. In December 2023, enfortumab vedotin plus pembrolizumab received full FDA approval for the first-line treatment of metastatic urothelial carcinoma. And this is based on the EV302 data, which randomized patients with metastatic urothelial carcinoma to receive enfortumab vedotin plus pembrolizumab versus platinum-based chemotherapy. And it showed almost a doubling of overall survival, which is really, really important for our patients. So we're so happy to have access to this combination right now in the first-line setting. And really, it's my kind of go-to combination right now because we do have it available in the United States. Erdafitinib is a targeted therapy that targets FGFR3 alterations, and it received full FDA approval for patients after at least one line of systemic therapy or post a checkpoint inhibitor therapy with metastatic urothelial carcinoma. Again, these are patients that have to harbor an FGFR3 or 2 alteration. And in March 2024, the combination of nivolumab plus gemcitabine and cisplatin did receive full FDA approval for the first-line treatment of patients with metastatic urothelial carcinoma. This is based on the CheckMate 901 data. Now, we saw these data being presented at ESMO, so this is a really short time period where we see these approvals. And it did show an improvement in overall survival. But if I have an option, I have access to enfortumab vedotin plus pembrolizumab, the overall survival was just so impressive with that combination that still is my go-to combination. And I also wanted to mention trastuzumab deruxtecan, TDXD. It's not a specific approval for bladder cancer. It's a approval for HER2 positive solid tumors following standard therapies, but because a lot of patients with bladder cancer have HER2 positive disease, it's an important approval to know, as this can be a potential treatment option for our patients. Now, today we'll be talking about the treatment landscape for metastatic urothelial carcinoma, and I wanted to start off with a case so we can kind of put this into context, and we'll start off with Mr. Joe. Mr. Joe is a 78-year-old man with urothelial carcinoma. He presents with gross hematuria. A CT shows a 3.5 centimeter mass in the bladder wall, lymph node involvement, and liver metastases. A biopsy of these metastases shows stage 4 metastatic urothelial carcinoma. He has a history of asthma, lives with his wife, he's a retired college professor, and has no history of smoking or alcohol use. On exam, he has an ECOG performance status of 1 and a creatinine clearance of 65 ml per mn. So what would be the first-line treatment for Joe? Well, we just talked about what are approved, some of the data that are ongoing, and we'll go through this in the context of the guidelines. But really, based on the current FDA approvals, I would say that enfortumab vedotin plus pembrolizumab would be the best treatment for this patient with metastatic urothelial carcinoma in the first-line setting because of really the impressive overall survival that it had over platinum-based chemotherapy. Now, Tian, what treatment options would you consider for Mr. Joe? And can you walk us through the current recommendation for first-line therapy and the role of available treatment based on these guidelines?
Absolutely. So, Andrea, I totally agree that because of the impressive both progression-free survival and overall survival data from EV-302, pembrolizumab and enfortumab vedotin is the approved and preferred, I think, in our practice, first-line therapy for metastatic urothelial cancer. The NCCN guidelines were updated at the end of March of 2024 to reflect that. And so you'll see enfortumab vedotin and pembrolizumab listed as a preferred regimen, both for cisplatin eligible as well as for cisplatin ineligible patient populations. And we have traditionally been thinking of these patient populations separately, but in this particular case, because EV-302 enrolled patients across cisplatin eligibility, this is the preferred regimen. And you'll see that these are category 1 and preferred. But there are certainly other recommended regimens. The Checkmate 901 data also showed an improvement combining nivolumab with cisplatin and gemcitabine. And so you see there's a category 1 indication for that. There's also from the Javelin Bladder 100 data, the gemcitabine and cisplatin followed by avelumab maintenance, and that's also a category 1. So if people are already on their chemotherapy and doing well, should continue with their care and still be able to see avelumab. And then under certain circumstances, dose-dense MVAC with growth factor support, followed by avelumab maintenance. This is also based on the Javelin Bladder 100 study. And then finally, in the cisplatin ineligible patient population, if patients also cannot receive pembrolizumab or enfortumab vedotin for some reason, gemcitabine with carboplatin followed by avelumab maintenance is preferred for category 1. And then there's also useful under certain circumstances. Maybe your patient cannot receive any PD-1 inhibitor. And then we're thinking about gemcitabine alone, gemcitabine paclitaxel, ifosfamide with doxorubicin and gemcitabine, or pembrolizumab or atezolizumab alone for people who cannot receive any chemotherapies. So that's the most recent version of the NCCN guidelines. And I think with the EV-302 data and Checkmate 901 data being released, this represents a really nice update for patient populations. Turning to the EAU guidelines, this is the European Association for Urology. Here they've laid out very nicely for us that patients who are eligible for combination therapy are approved to receive enfortumab vedotin with pembrolizumab, although as Andrea mentioned, there can be some access issues outside of the US in terms of whether these treatments are fully reimbursed in those countries. countries, but certainly it is recommended where available. For those patients where enfortumab vedotin is not available, they also have platinum with gemcitabine with maintenance avelumab or cisplatin gemcitabine with nivolumab as potential options. And so hopefully these represent the majority of patients. Even if they don't have access to enfortumab vedotin and pembrolizumab, they have options to receive other combination strategies. And then if patients are not eligible for a checkpoint inhibitor, platinum with gemcitabine is the recommended combination. And if they're ineligible for a combination strategy and are looking at single agents, there's a PD-L1 positive selection for either atezolizumab or pembrolizumab, and then also best supportive care. And then finally, for the ESMO guidelines, for patients with treatment-naive advanced or metastatic urothelial cancer, these patients are recommended to receive enfortumab vedotin and pembrolizumab. And then if they're treatment-naive with advanced disease, when enfortumab vedotin and pembrolizumab is unavailable or contraindicated, then we're splitting patients up into that cisplatin eligibility, very similar to the other guidelines we've looked at. And patients eligible for cisplatin are recommended to receive nivolumab with gemcitabine and cisplatin based on Checkmate 901. And then the patients who are potentially carboplatin eligible, they're going on to receive gemcitabine with carboplatin for their chemotherapy selection. And so finally, we're showing here now some clinical trial data. You've heard us mention EV-302, also known as Keynote 839, as the enfortumab vedotin with pembrolizumab compared against chemotherapy trial in the frontline setting. And that showed an improvement of median overall survival for EV with pembrolizumab of 31.5 months versus chemotherapy at 16.1 months with a hazard ratio that was quite favorable at 0.47. Checkmate 901, you've also heard us mention several times now with nivolumab, with gemcitabine and cisplatin versus gemcitabine and cisplatin, show an improvement also in median overall survival with a hazard ratio here of 0.78. And then Javelin Bladder 100, which is the basis for our maintenance avelumab strategies after chemotherapy, with 1 year overall survival improvement, hazard ratio 0.69. And at the 3-year follow-up, the overall survival showed an improvement with a hazard ratio there of 0.76. So certainly across these 3 phase 3 trials, we've seen an improvement in our survival outcomes and metastatic disease. And hopefully many of our patients in the frontline setting are having access to some of these treatment strategies. So let's go back to our case. Here, our patient, Mr. Joe, has now been treated with enfortumab and vedotin and pembrolizumab, and is now presenting for restaging scans about 8 months after responding to treatment. And now his CT scan shows an enlarging pelvic lymph node as well as liver metastases, unfortunately. His next generation sequencing shows an FGFR3 mutation. So Andrea, can you talk us through the second line treatment options for Joe?
Thanks, Tian, and thank you for that summary. I wanted to go back and talk about the FDA drug approvals. A lot of things are not yet available in Europe. A lot of these combinations have been submitted for approval, so they've been filed, but they're still pending. And that includes enfortumab vedotin plus pembrolizumab. It's been successfully filed for EMA approval, but still pending approval. Same thing for erdafitinib, which we talked about is FDA approved, also has been filed, but pending approval. And the combination of nivolumab plus gemcitabine and cisplatin, again, also filed, but still pending approval. So let's start off with the NCCN guidelines. It divides it for patients that have received platinum-based chemotherapy in the frontline setting, and then patients that have received checkpoint inhibitor. Now, it's a little bit tricky because enfortumab vedotin used to be given as a third line, and checkpoint inhibition with PD-1, PD-L1 was previously given as a second line. But now that we're combining basically second and third line and becoming frontline, what do we then give in the second line setting? Everything basically that was frontline is being shifted into second and third line. So for our patient, Mr. Joe, who got EV plus Pembro, I would next offer him platinum-based chemotherapy per the NCCN guidelines that's in there. And then we can see, is he cisplatin eligible, or does he need to get carboplatin? Well, remember, his creatinine clearance was 65, so that makes him eligible for cisplatin. So we can go ahead and treat Mr. Joe with cisplatin combination. And for him, we chose gemcitabine and cisplatin. If we look at the EAU guidelines, they divided by patients that actually received EV plus Pembro. So again, these guidelines were updated this year, so we're really fortunate to have these. And for patients like Mr. Joe, if we look at the first column, who got EV plus Pembro, you have the option of platinum-based chemotherapy. You also have the option of FGFR3 erdafitinib, also sacituzumab govitecan. Now remember, for erdafitinib, you only give that for patients that are FGFR3 or 2 positive that have an alteration. Our patient did have an alteration, so erdafitinib is an option for him. And whether to give chemotherapy or erdafitinib, I would say chemotherapy is although it's combination treatment, it does have a higher response rate in the first line setting. So I would probably favor giving platinum-based chemotherapy to our patient in the second line setting. And although the patient is FGFR3 positive, saving erdafitinib for third line treatment. But this is a discussion to have with the patient in terms of the sequencing of therapy. And we're still learning as to what the right sequence is. And it can be very confusing because we have all these treatments that are now moving into earlier lines of treatment. And there's also the access issues. And if we then now look at the ESMO guidelines also suggest that the patient received EV plus Pembro, consider platinum-based chemotherapy, consider erdafitinib. So really all in line with kind of what we've discussed so far. And for our patient who got EV plus Pembro, second line went on to receive platinum-based chemotherapy with gemcitabine and cisplatin. So Tian, even with these newer options, many patients then may require third line, fourth line. So why don't you walk us through what you would do in this setting in terms of next lines of therapy, specifically using Mr. Joe as an example?
Sure. Andrea, I think it's tremendous that we've made so many opportunities and changes to expand not only first line, but also subsequent line treatment. And these sequencing are certainly still under a lot of our active research programs, and we're thinking about how best to sequence these strategies. But as newer therapies, as you pointed out so eloquently, are being moved into the earlier line settings, we're now having more options to think about for further line treatments. So if we look at the NCCN guidelines for Mr. Joe, who has now progressed after prior enfortumab vedotin with pembrolizumab and now gemcitabine with cisplatin, and keeping in mind his FGFR3 alteration, the NCCN guidelines has some preferred regimens in subsequent therapy with either enfortumab vedotin monotherapy or with erdafitinib specifically for patients with FGFR2 and 3 alterations. And so we have options for this patient. For him, I would personally choose the erdafitinib option as a third line option for him. But there are other recommended strategies like sacituzumab govitecan, which is another antibody drug conjugate targeted to TROP2, gemcitabine on its own, paclitaxel or docetaxel monotherapy. These are taxane chemotherapies that we've used in bladder cancer and refractory bladder cancer from a while ago. And then also ifosfamide, doxorubicin, gemcitabine as a combination chemotherapy strategy, gemcitabine with paclitaxel, or if somebody has not had gemcitabine cisplatin, to use gemcitabine cisplatin or Dostansembac in the refractory setting. I would say in my practice, those patients receiving either gem cisplatin or Dostansembac in the third line or beyond setting is quite low. There's not that many patients who haven't seen them either upfront or in the neoadjuvant setting. So I'm not using those strategies quite so much in the refractory setting.
And we haven't talked about that, Tian. That's another issue, is that a lot of these agents are being used earlier in the neoadjuvant setting, which make guidelines a little bit more complex, right? Because if they receive neoadjuvant platinum-based chemotherapy and then went on to receive nivolumab in the adjuvant setting, then they've kind of used up a lot of the treatments that we use for metastatic disease. How will we sequence these patients? Is EV plus Pembro still a good option if they've already received a checkpoint inhibitor? We don't know the answer to these questions, and I think clinical trials need to be done in order to answer this. I think somebody who progresses immediately or on a checkpoint inhibitor in the adjuvant setting is not the same patient than someone that progresses, a year or two later with metastatic disease after receiving neoadjuvant and then adjuvant therapy, and then thinking about what to give them in the first line setting. Maybe a little bit simpler because maybe you could re-challenge with a checkpoint inhibitor, but we don't know the answer to that. And what to do, I think we're still learning.
Absolutely. To your point, I think some of us are generating, there's the Unite group, I'm sure that's looking at real world data and outcomes of VV Pembro after adjuvant nivolumab as these as our practices are changing and adapting, right? But we don't know what the activity of these combination strategies will be after prior neoadjuvant, adjuvant treatments and exposures to those treatments. And potential re-challenge, right? So sometimes patients will have, depending on their timing of recurrence and metastatic disease, either re-challenge or continuation of their checkpoint inhibitor as enfortumab vedotin gets added. So really pertinent research questions. I absolutely agree with you. We can turn for a moment to the EAU later line therapies. Again, here it's really based on prior treatments. Patients previously treated with enfortumab vedotin and a checkpoint inhibitor. Subsequent treatments are platinum with gemcitabine, or if they're FGFR positive, erdafitinib. Sacituzumab govitecan also has its space, as well as single agent chemotherapies and trials. If the patients are pretreated with a platinum chemotherapy with and without a checkpoint inhibitor, then perhaps enfortumab vedotin as a monotherapy still has its role. And again, if they're FGFR positive, then erdafitinib on its own. Many of the other strategies are very similar to people who have had prior EV and checkpoint inhibitor. And if they're pretreated with a single agent, then all of these other strategies also are helpful. And often we're sequencing monotherapies versus thinking about trials for those patients. So in every box, the bottom bullet, you'll see here, consideration of clinical trials as newer therapy options are available.
Absolutely. And I just wanted to mention for our patient, Mr. Joe, he got EV plus Pembro, then he got platinum-based chemotherapy. And that's kind of the order that I use in my clinical practice. And then he's FGFR3 positive. So then he got erdafitinib, which has a higher response rate, about 40% response rate in the second and beyond setting, compared to sacituzumab govitecan, which is also an option that has a little bit lower response, 27%. So if possible, and if no contraindications, I would use erdafitinib before sacituzumab govitecan. And I couldn't say it better, Tian. I think really if there's availability of a clinical trial, enroll your patients in a clinical trial, because understanding the sequence and understanding and having access to new drugs is really important for our patients.
Super critical. And I know you and I have multiple trials in the metastatic urothelial space that we would love for our patients to go on. So absolutely. So wrapping up with the ESMO guidelines, again, it's really dependent on prior treatments and what they're exposed to, EV with Pembro, then platinum-based chemotherapy or erdafitinib for FGFR altered patients. If they're cisplatin eligible versus ineligible, then thinking through other chemotherapy options. And if they've had progression after that, then considering erdafitinib, again, for the FGFR altered patient population, enfortumab vedotin as a monotherapy, sacituzumab govitecan, or single agent chemotherapies. Vinflunine is also a possibility, or the taxane chemotherapies. And then thinking through trial options, I think, is always an important consideration for our patients. So, Andrea, we've certainly covered a lot of information so far. And how would you summarize the current role of guidelines in our treatment of metastatic urothelial cancer? What questions remain, and what do you think are our future directions here?
There are many new therapies for the treatment of metastatic urothelial carcinoma, and the best treatment sequence is still under investigation. And guidelines may not always be able to keep up with the pace of research and the approvals, and really the patient in front of you who has received prior therapy, especially now that a lot of the therapies are being moved into earlier sets of disease, and how to manage these patients, we still don't know yet. But I think an important point is to always consider a clinical trial if available for your patient. Tian, what would you say are the key takeaways from our discussion?
Well, we've covered a lot, Andrea, but importantly, these are patients who are coming to our practices with metastatic urothelial cancer. We have a lot of treatment options for these patients, and we've covered very in-depth the most recent metastatic urothelial cancer treatment guidelines from NCCN, EAU, and ESMO. Hopefully, that's being spread out to our colleagues in community practice, and they're getting really familiar with these treatment sequences for their patients with bladder cancer. There are multiple new agents that have been recently approved or now under review through regulatory agencies and hopefully are making a difference for patients with metastatic bladder cancer. I think guidelines can be helpful for sequencing treatments, but may not always incorporate all of the newly approved agents. Remaining up to date with our clinical trial data for new agents is certainly essential with active clinical practices to provide the best clinical care for our patients. And research is ongoing for treatment of metastatic urothelial cancer, and we hope that further approvals are likely in the near future. So with that, Andrea, thank you so much for joining, and also thank you to our audience very much for joining us. Please complete the post polls in the tweets below or by using the QR code shown on the screen. And please don't forget to claim your free CME credit. Click the like and follow for more social media-based CME from Bonum CE.